bill that I'm co-sponsoring along with one of my Democratic colleagues, the Special Registration for Telemedicine Clarification Act of 2018. And you mentioned that it is available now that you can, through telemedicine, that you can get a waiver in order to write a prescription for an opioid or for a pain medication without seeing the patient, but seeing them through telehealth. Is that right?
It's not a special waiver from what I understand. Telemedicine under the Ryan-Haight Act
Right.
has been outlined as far as there's certain situations that you can follow and you can engage in telemedicine.
But the Ryan-Haight Act limits that. But nevertheless, the intent of this bill that we are co-sponsoring, Representative Buis and myself, is to allow or to direct the agency to come up with and to promulgate the rules so that we can do this, so that it can happen, because this is extremely important, particularly in rural areas where telemedicine is vital, and particularly for patients who need that pain medication who may not have access to a professional at that time.
I agree that telemedicine is definitely needed, but again, when I put my regulatory hat on, and my main concern is diversion.
I understand, and do you feel like this is something that you can do? Because what we say in this legislation is to direct the agency to come up, the DEA, to come up with to promulgate the rules within 30 days of the passage of the law.
I understand.
Okay, well, I just want to make sure, and certainly we're concerned about the fraudulent use of it as well. So, another bill that I'm co-sponsoring, again, along with one of my Democratic colleagues, Representative Mark DeSaulnier, is empowering pharmacists in the Fight Against Opioid Abuse Act. And that, of course, is for the DEA to help pharmacists to identify fraudulent prescriptions, and that's something that's very important. For your information, currently I'm the only pharmacist serving in Congress. I practiced for over 30 years, and I have to tell you that this is something we do need help with, and we welcome this help. We want to have the ability to identify fraudulent prescriptions. However, you have to keep in mind that we're not law enforcement officers. The only thing worse, I think, for myself as a practicing pharmacist, the only thing worse than dispensing medication that would be opioids in particular, that would be for abuse and for diversion, would have been to deny a prescription to a person who truly needed it. That's very difficult. I don't want to have to profile. It's unfair for you to expect me to have a patient come in and for me to make a decision by looking at that patient and saying that, you know, they don't look like they need this, that I'm supposed to keep them from having it. That's simply not right and something that I'm not trained in. So I hope you will keep that in mind during the time that you're looking at it. Another thing I wanted to touch on was what we did in CARE, the Comprehensive Addiction Recovery Act, is to allow 3 prescriptions for a 30-day supply to be written. One of the things that has been suggested, and it was just mentioned, was the fact that possibly allowing physicians to have a refill on a prescription on a smaller amount. All of us in pharmacy have experienced getting a prescription for for a simple dental procedure for 30 oxycodone. And that's something we hate to see. So I hope that the department will look at possibly allowing for a smaller quantity with perhaps just 1 refill that has to be filled within a certain time period. That's something that I hope you will look at as well. One of the things that concerns me is, look, there are rogue practitioners in every profession, including the medical profession and practitioners. And one of the things that concerns me is that I've never had a doctor who said, I didn't know opioids were addictive. Physicians are smart people. They're intelligent people. They've gone through intensive training. They understand it. They do need to have continuing education with it. But it does concern me, and it concerns me on how long it takes for the DEA to respond to some of these rogue doctors sometime. I hope you'll look at that. The last thing I wanted to touch on is when I was a member of the Georgia State Legislature, every year we have a Dangerous Drug Act, and we include drugs into the Schedule I classifications in our state. I did that on numerous occasions. It's very difficult. It's going to be very difficult with you with the synthetic drugs. I know how they get around it. I just want to ask you, after it becomes a Schedule I drug, a state can't overrule you and say that that could be legal, can they? You know where I'm going.
I know where you're going.
Okay.
Federal law
Yes
is
or no?
federal law.
Yeah, yes or no?
And if federal law identifies a substance to be Schedule 1, it is Schedule 1.
Okay.
We're not going
Can
to...
I ask you one question?
Yes, sir.
What is marijuana?
Schedule 1.
Thank you very much. Mr. Chairman, I yield.
Chair thanks the gentleman. Gentleman yields back. Chair recognizes the gentleman from Kentucky, Mr. Guthrie, the Vice Chair. Mr. Carter, 5 minutes for questions, please.
Thank you, Mr. Chairman. Mr. Chairman, before I start, I want to compliment you and staff for this is an outstanding panel. I mean, seriously, we got boots on the ground. So often, with all due respect, we only have people from academia, but this is truly boots on the ground. And I just can't tell you, I'm so impressed. I'm sorry I had to leave a little earlier to go meet with another group, but let me get started because I got a lot I want to go through. And I'm going to start with you, Dr. Khan. I want to ask you, because telemedicine, I've got a bill that we're considering with telemedicine, but specifically with the Ryan Haight Act. It limits expanded access to buprenorphine. And I'm just wondering if you could speak to that very quickly about how we could do away with that so that we could be able to prescribe it if we needed to, but because of this act, as I understand it, we're not able to.
If we amend it to the recommendation that we can rely on another provider, that would be extremely helpful. With my company, we rely on emergency department physicians. We've paired with emergency departments to identify, get them started on buprenorphine, and quickly matriculate it into care. The short version of it is that the drug dealers are open 24/7.
Right,
we need to be ready to do the same.
Right. Mr. Nance, you mentioned this also in your testimony about the limitations that Ryan Haight Act is causing us on that. Can you comment on that very quickly?
Can you ask me a more specific question?
And just about, particularly, as I understand it, it limits the expanded access to treatment with some of the drugs that we need to be treating this opioid addiction with, like buprenorphine.
Yeah, the whole point of my testimony is that, especially in rural and frontier areas in the country,
Absolutely.
you have very, very few licensed providers who will actually be willing to provide buprenorphine. In Utah, we have, my friend in the DEA in Utah says we have 503 licensed, trained buprenorphine prescribers. Only 125 of them are actually practicing and prescribing buprenorphine. But if you go on the buprenorphine treatment finder on their website, there are only about 70 listed.
Right.
So you've got a huge potential labor pool out there, but they're just reluctant to do it.
But
because they're not
specifically
familiar
with telemedicine, if we were able to have the physician be able to prescribe it then, as I understand that they can't because of the Ryan Haight Act.
Right, it's very, very difficult. You have
Right.
to have that first face-to-face.
Okay.
If we can get the community behavioral health centers included as a kind of a separate definition inside the Ryan Haight Act, then we can open up a lot of potential buprenorphine services to
Right.
patients in those extreme.
Okay, let me move on. Mr. Logan, I wanted to ask you, did y'all ever get the PDMP in Missouri?
I keep getting asked these questions with long answers.
Well, okay, I need you to make it real quick.
We
Yes or
have-
no?
We have an executive order signed that examines prescriptions written and adjudicated through a third-party insurance and prescribes blame to overprescribers.
Okay. You really need it.
We
You know,
got
for
nothing.
many years, for a long time, 49 out of 50 states had it. Missouri was the only one who didn't have it. And it needs to go across state lines. As you pointed out earlier in your testimony, you're right on the state line, and you're going to get prescriptions, as I did in my pharmacy, from many states, so that's why it's so very important. I wanted to mention just a couple of other things. Mr. Cosgrove, you mentioned that a number of companies, pharmaceutical manufacturers, are moving overseas. Is that because of our tax laws? We changed that just recently, so I hope that we've resolved that.
Well, I'm not an expert in tax law.
Right.
I do know that the manufacturing costs overseas, for a number of reasons,
Okay.
are dramatically lower than
Well, if it's because of the manufacturing costs, but if it's because of the tax problems, then we have resolved that problem with the Tax Cuts and Jobs Act. So I want to make sure we understand that. Dr. Suvith, you mentioned about the new drug that you had. I just wanted to ask you very quickly, you having to use specialty pharmacies, only practitioners going to be injected. Was that mandated by the FDA, or did the company decide that's the way that you wanted to go? Because access is a big problem when we're talking about these kind of drugs. And obviously that's going to limit access there.
So this was in discussion with the FDA. It's part of our risk evaluation mitigation strategy program.
Okay.
Because a lot of doctors, some of them do not want to do the buy and bill. And so there had to be another way in a restricted distribution system. So if a doctor in Utah wanted to prescribe Sublocade, they can contact one of the specialty pharmacies that we're working with.
Right.
They will get a named patient for a prescription that'll be sent to that doctor for use only in that patient.
Okay, and one last thing, Dr. Mulder, thank you. I was a hospice consultant pharmacist for many years, and quite often in Congress, we have the tendency to overreact and overdo it, and you pointed out something that's very important. There are people out there who truly need these drugs. We need to make sure that they're going to be able to get them and have access to them. So thank you for pointing that out.
Amen.
Yes. Thank you, Mr. Chairman. I yield back.
Gentleman yields back. Chair thanks the gentleman.